So this is, we have a special guest today for the Jerry Reaven Memorial Lecture. So we have Dr. Ralph Defronzo from UT Southwestern, where he is the director of Diabetes Institute and chief. Like Jerry, Dr. Defronzo is one of the leaders. He's just one of the pillars of diabetes, and has really shaped the way we understand the physiology and how to treat it. And he was a good friend and colleague and a highly respected one. And those are those are harder to find. But you know, one of the highly respected friends of Jerry's. So we're very honored to have him. He competes with Jerry for publications. In fact, I believe you topped him. He has over 866 peer-reviewed papers. He has won the top awards, rightly so. The Banting Award from the ADA and the Claude Bernard from the European Diabetes Association. And he lectures in a way that is actually similar to Jerry too. Just he distills it down to the most important things. Jerry always wanted to do that with all his papers and his lectures. You'll see a bar graph with 3 bars instead of a whole bunch of data. And it's a very effective way to teach and a very effective way to approach physiology. And you'll see that Dr. Defronzo does the same thing. So I'm going to turn it over. Thank you so much for coming out and seeing us and giving this special lecture. I know Jerry would be so thrilled.
Yeah. Well, Tracy, that's a beautiful introduction. Tracy and I are very, very good friends. So Jerry and I actually were very close. For better or worse, people said that my personality was very similar to Jerry's. Jerry could be obstinate at times, for those of you who know him, but he was always, he was a fantastic teacher. He liked working with people. He had brilliant ideas. And when I was a young person starting off, Jerry invited me to give my first lecture overseas in Bologna. And Bologna is the sort of gastronomical capital of the world. I'll never forget this day. So Jerry is known for a lot of things, but he loved wine, red wine, and he loved food. And he told me he was going to take me to dinner at this gastronomical place in Bologna. And so we started off walking, and we walked for about a half mile. And I said, Jerry, you sure you know where we're going? And he said, oh, yeah, you'll love the place. So we finally got there, and I said, is this the place? And he said, yeah, it says Sam's Place. I said, we're in Italy. I can't believe that Sam's Place is going to be here. And then I'm thinking, well, maybe he doesn't know so much about food and wine. Well, the dinner was fantastic. The wine was even better. So we had a phenomenal experience. And many of the things that I do, actually, Jerry was my idol, or sort of developed along the same line of thinking that he had. And a lot of work, what I'm going to tell you about today, actually falls right in line with what he's doing, and a lot of things that Tracy is doing as well. So I'm going to talk about the treatment of type 2 diabetes, but I'm a big believer that if you're going to treat a disease, you need to know what's the pathophysiology. You can't just put people on drugs and expect that, well, here we're talking about glucose or A1C, that it will drop, it will stay down. But if you understand the disease and then you develop medications to reverse the underlying defects that are present, it's very likely that on a long-term basis, you'll get the disease controlled. So these are my conflicts of interest. But I wanted to show this slide to start the presentation, because a lot of what I'm going to say really is related to what Jerry said. So this is from Jerry's very famous Banting lecture. I would call Jerry the father of insulin resistance. I'd be happy to be called the son of Jerry. I was sitting in the balcony when he delivered this lecture many, many years ago. And the people, and the topic was the insulin resistance syndrome and the metabolic syndrome and syndrome X. And the people around me were saying, God, that is the most ridiculous thing I have ever heard in my life. And I was sitting there saying, this is brilliant. This is like a phenomenal, critiques. And many, many years ago, Jerry came up with this notion that insulin resistance was an integral part of type 2 diabetes and prediabetes. And he actually used a different technique when he initially started the steady state plasma glucose concentration. But these data are with the insulin clamp technique, something that I developed, I'll talk about a little bit before and more. And he infused insulin, and then using radioisotopes, you can measure total body glucose uptake. And the orange bar is how much glucose in response to a fixed dose of insulin, a healthy, normal glucose tolerant person metabolized. Someone with prediabetes, impaired glucose tolerance, you can see the dark orange, sort of red bar. There was a significant decrease in their insulin sensitivity. And in the purple bar, the people with type 2 diabetes, you can see they were very, very insulin resistant. And he was the first person to put forward this insulin resistance or metabolic syndrome. So that diabetes was not just insulin resistance, it was insulin resistance, it was diabetes, it was obesity, it was hypertension, dyslipidemia, and cardiovascular disease. And all of this really has stood the test of time. And you'll see many of the thoughts as I take you through this presentation today, really are founded in what Jerry said many, many years ago in his famous Banting lecture. So diabetes is a very, very serious problem. And I like to use this slide to introduce things because it gives you a picture of what's going on every 24 hours. This is not every month. This is every day. There are about 4,000 new cases of diabetes, mostly type 2, are diagnosed. That's really a staggering number. You can see 800 people die every day from diabetes. There are over 200 amputations every day in people who have diabetes. Kidney disease, it's the commonest cause of end-stage kidney failure now. Over 50% of people entering dialysis units have diabetes, and every day 50 or so people go blind. So this is a serious disease. And unfortunately, because it comes on in adulthood and it takes many years for all these things to develop, it doesn't get the same kind of attention. If someone had cancer, immediately, of course, we sort of mobilize the troops. Cancer is a serious disease, but type 2 diabetes, actually, in terms of the number of people, outdwarf the number of people who die from cancer, and it's much more costly, but we never think about it this way. So how well are we doing in terms of getting people in terms of their glycemic control in line? So what I plotted for you is on the x-axis going from year 2000 to present, and the white line is the percentage of people with an A1C above or less than 7, which is kind of the ADA treatment goal. And you can see half of the people have an A1C that's above 7. And then the orange curve is the percentage of people above or below an A1C of 8. You can see 25% of the people have an A1C above 8. So clearly, we're not doing such a great job in getting people controlled. So why is it that we fail? Well, at the top of the list, I put the treat to fail approach. We start people on drug A. It's usually the wrong drug. It's metformin. And you fail. You're guaranteed to fail. And then after you fail, we add the second drug, which is a sulfonylurea, and you fail, guaranteed to fail. And then when you fail, we add the third drug, which is a DPP-4 inhibitor, and you are guaranteed to fail. And eventually, you're going to end up on insulin. Physician inertia. A1C comes back, they see the A1C is 8, 8.5, and they do nothing. And it oftentimes takes 2 or 3 or 4 years for people to add a new drug, increase the medication dose. Patients, if they want to defeat you, I guarantee you lose 100% of the time. So Nurse educators, dietitians, very important because we as physicians don't really have enough time to educate the patients to convince them that what they do today makes a difference 10 years from now. Cost of medications, particularly the newer ones, some of the new ones we'll talk about, $1,000 a month. They're fantastic drugs, but not too many of my patients can pay $1,000 a month. And then what I think is the big problem is a failure to understand what causes the disease and using drugs that don't correct the underlying pathophysiology. So when I gave the Lilly lecture at the American Diabetes Association in 1987, this was the Young Investigator Award. Our concept of what caused type 2 diabetes is very simple. I just called it the triumvirate, 3 problems that we had to deal with. We know that there's insulin resistance in the liver, insulin resistance in the muscle, and beta cell failure. So let's start with insulin resistance in the liver. We were actually the first people to use radioisotopes to quantitate hepatic glucose production. When you go to sleep at night, your brain has an obligate need for glucose, cannot use any other metabolic fuel. So you go to sleep, your fasting glucose is 80, you wake up in the morning, your fasting glucose still 80. Well, that's critical because that is going to be the fuel that your brain is going to extract and use throughout the sleeping hours. Well, it turns out the liver is very, very resistant to insulin. So when you go to sleep at night, your liver overproduces glucose. So in the morning, that increase in fasting glucose that diabetic has is all due to insulin resistance in the liver due to accelerated gluconeogenesis. So we're going to need drugs that shut down hepatic glucose production. Muscle. So you wake up in the morning, you may start with an elevated fasting glucose, and now you're going to have a meal. The carbohydrate that's in the meal needs to be taken up and disposed of in the muscle. The muscle is very resistant to insulin, postprandial hyperglycemia. And then, of course, beta cells are type 2 diabetic patients are programmed to fail. And of course, if you're insulin resistant and you have this genetic tendency to fail, the insulin resistance puts stress on your beta cell. And as your beta cells fail, your A1C goes up. So 1987, pretty simple. Okay, this is the triumvirate. When I gave the Banting lecture, however, in 2008, it was titled From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. Disease much, much more complicated than we thought. Now, I could add a few more to this, which I'm not. The point I want to make is if you have a disease, and I'll come back to this again, that has at least 8 underlying pathophysiologic disturbances, there's no way in the world one drug is going to correct 8 problems. So bottom left, liver, insulin resistance. Bottom right, muscle, insulin resistance. Upper left, beta cell. So what are these other 5 guys? Fat cell in the upper right. So what's driving the epidemic of diabetes today is the epidemic of obesity. We overeat. And as long as there's enough storage in the fat cell to take those excess calories, the fat will stay there, can't hurt you. But as the fat cells expand, they become very resistant to insulin. And now you start to break down the triglycerides, you release the FFA into the bloodstream. Elevated FFA, these are studies that we did many years ago, but in fact, long before we did them, Jerry did them. We did them with C14 palmitate. Jerry did them with just measuring the plasma FFA level. The FFA levels are increased and they don't suppress. Elevated FFA impaired beta cell function, and we went on to show at the molecular level how this happens. Elevated FFA stimulate hepatic gluconeogenesis and cause insulin resistance in the liver and the muscle. The defect in the fat cell is causing an exacerbation of the problems in the other 3 organs that are big guys in the development of type 2 diabetes. The gut at 12 o'clock is a giant endocrine organ. So every time you eat a meal, you release 2 incretin hormones, glucagon-like peptide 1, GLP-1, and GIP, glucose-dependent insulin-trophic polypeptide. Those 2 incretin hormones account for 75% of the insulin that comes out every time you have a meal. The problem is your beta cells have become resistant to GLP-1 and GIP. So we have a drug, a whole series of drugs. We give you an injection of a GLP-1 receptor agonist, and we overcome the beta cell insulin resistance, and we can do a pretty good job at normalizing beta cell function. At 9 o'clock is the alpha cell. So Dr. Roger Unger in Dallas showed many, many years ago that diabetics had elevated glucagon levels in the fasting state, and they don't suppress normally in response to a meal. And those elevated glucagon levels drive hepatic glucose production throughout the sleeping hours. At the right, the kidney, which I have a big interest in, we'll talk a little bit more about this later. The kidney comes into play in a somewhat different way. So I know you all remember this from your renal physiology days, but when you eat a meal and your glucose goes up and it goes from 100 to 120 to 150 to 180, no glucose appears in the urine. But once your glucose gets to 180, that's the threshold for spilling glucose in the urine. But diabetics, it turns out, as they become more and more hyperglycemic, that threshold for spilling glucose in the urine goes up. And in many diabetics, and I'll come back to this, their threshold for spilling glucose may be 260, 270, 280. So the diabetic kidney, instead of dumping the glucose in the urine, is holding on to the glucose, okay? And then lastly, the brain. The brain plays an important role in the pathophysiology of type 2 diabetes, but in a somewhat different way. So every time you eat, you release a number of appetite suppressant hormones, GLP-1, GIP, amylin, and others, that send a signal to your brain, say, stop eating. Well, it turns out your brain has become resistant to these appetite suppressant hormones. And of course, that's driving the epidemic of obesity. You eat more. The hedonic areas in the brain are activated. Everything that looks good looks even better. You eat more, you gain weight. And when you gain weight, that causes insulin resistance. So it should be obvious that if you got 8 problems, and as I said, I could add a few more to this, there's no way one drug is going to control 8 problems. We in the diabetes field are the only people who use one drug. You know, if you're taking care of cancer patients, there are 3 or 4 drugs. If you're taking care of hypertension, the average person is on 3 or 4 drugs, okay? If you have AIDS, the patient is taking 3 or 4 drugs. Only we have not caught on that this disease is complex and it's going to require combination therapy from the beginning. And when you pick the drug, if you simply pick a drug that lowers the A1C, and I'll show you what those drugs are in a second, the A1C may come down initially, but it's just going to go back up, okay? And then lastly, we got to start early, because if you now wait too long and you start to lose beta cells, there's nothing you're going to do to get those beta cells back. The patient's going to end up on insulin therapy, okay? So what drugs work and what drugs don't work? So I'm going to take you back to the United Kingdom prospective diabetes study. So this is Dr. Robert Turner's study. And many of you, some of you are old enough to know what I'm going to say. Many of you here, most of you here are not old enough. So at the time this study started in the 1980s, there was an enormous debate in the diabetes literature as to whether good glycemic control made any difference in terms of the microvascular complications. And half of the diabetes field felt like it doesn't make any difference. You can control the A1C, you're still going to go blind. The other half of us, I was in the other half, and as was Jerry, we believed that good control was important. So Dr. Turner said, I will do a study to try to sort this out. So this study I'm going to tell you, UKPDS, this is the first big study showing that good glycemic control made a difference. And so what he did is he took newly diagnosed diabetics with an A1C of 7, and then there are about 4,400 people in this study. 1/3 of the people got on diet and exercise. And you can see the yellow curve. And the A1C starts at 7 straight up over 15 years. And if we had paid attention, we would have learned from what he did, you know, like 40 or 50 years ago, diet and exercise still does not work on a long-term basis, okay? And he had some crude measures of beta cell function. HOMA-IR is okay, HOMA-beta is not so great. But in either case, what he showed is at the beginning, all these people were insulin resistant. And the reason why the A1C went up was because of beta cell failure, okay? So then he said, I'll put one group on metformin. Metformin works on the liver. It's a misconception that metformin is an insulin sensitizing drug. Metformin gets into cells through the organic cation transporter, and the organic cation transporter doesn't exist in muscle. So it cannot possibly even get into muscle to be an insulin sensitizer. Yet, if you read in textbooks, they still talk about metformin being an insulin sensitizing drug. It's impossible. And we've also done insulin clamp studies and shown it has no effect on insulin sensitivity whatsoever. But it does work on the liver. And you can see in the first first year, A1C comes down, that's the orange curve. And then what happens? Straight up, beta cell failure. What's the other drug that's in this study? The third drug is glibenclamide. This is glyburide. It works, binds to the sulfonylurea receptor in the beta cell, kicks out insulin. Insulin overcomes the insulin resistance. A1C comes down in the first year. And then what you see, straight up. So what Dr. Turner noted was here at 5 years into this study, they had come back to an A1C that was where they started. So he wrote 5 papers, BMJ, Lancet, Diabetes, Diabetes Care, Diabetologia, all journals that we're familiar with in the diabetes field. And he said, my hypothesis is not correct. You cannot put people on a single oral agent, have the A1C come down and stay down. So he said, I'm going to change the study design. So if you're on sulfonylurea, he added metformin. If you're on metformin, he added sulfonylurea. And then he said, look, if necessary, I add insulin, okay? So at 15 years, now everybody is on metformin and sulfonylurea, and 65% of the people are on insulin. Now, if you read up and you'll go across, the A1C is 8.8. Now, if you want to kill your patients, this is a very good therapy, okay? They're guaranteed to go blind and develop kidney failure. So this has been known. Remember, this study started in the 80s, is known in the 1990s, okay? Literally until the last 2 years, this is the American Diabetes Association algorithm. I put you on metformin, and when you fail, I add a sulfonylurea, and then the third most commonly prescribed drug in the United States are DPP-4 inhibitors. You can pick up any journal, and that's basically what doctors do in the United States. Now, I've taken you through the drugs, but that's actually not why this study was carried out. The study was carried out to see if I control the glucose, could I decrease the microvascular complications? And they did. The separation between the yellow curve, which is diet and exercise, is kind of the control group, and the drug group decreased ischemia and nerve complications by 37%. So this was the first study in type 2s showing that good control made a big difference. But it also told us what drugs were going to work and what drugs were not going to work. And interestingly, no one ever talked about the lack of these drugs in terms of controlling A1C, okay? So this is what I call the 15-year revelation. So you think we would be smart enough from the UKPDS to figure out that this combination doesn't work. Well, what we've shown repetitively every 15 years, they were not very smart, okay? So the ADOPT study came in 2005, and I'm going to show you the data in a second. This is Dr. Steve Kahn's study. So they repeated UKPDS, okay, with metformin and sulfonylurea. You know what? They got exactly the same result after the first year you fail. So you say, okay, we screwed up twice, okay, maybe we get smart, all right? So 15 years later, we have the GRADE study, okay? So you would think that, the GRADE study, you think it's going to show something different from these 2 previous studies? No. So every 15 years, we waste hundreds of millions of dollars doing the same study, which we know is going to fail. So here now is the ADOPT study by Stephen Kahn. So metformin is in yellow, glyburide is in pink. You see A1C starts about 7.2, 7.3, comes down in the first year, and then what happens? And the rate of rise in A1C is identical to what we saw in UKPDS. Okay, you think, okay, we should catch on. So now came the blockbuster study that spent, I don't know, billions of dollars, funded by the National Institutes of Health. And for those of you who lost your NIH grants, you can blame David Nathan for this stupid study, okay? So to get into this study, you had to have failed on metformin, all right? So then they wanted to know, what is the best drug to add to metformin? Well, first, you failed on metformin, so you've already shown that metformin doesn't work. That was the criteria to get into the study, okay? So the white is the glimepiride. So what happens? You get a kick out of insulin. You can see A1C comes down, and then it rises. Okay. Next, sitagliptin. This kid wasn't around when UKPDS started. This is a DPP-4 inhibitor. Same thing. A1C comes down, and you fail. What was very surprising to me, because I actually thought liraglutide, which is a GLP-1 receptor agonist, would work, but it also failed. Okay. And then I thought, well, second best would be insulin. But the problem is doctors just don't titrate the insulin up fast enough. And then hypoglycemia becomes rate limiting. So what we learned is, oh, yes, we could repeat UKPDS. Oh, yes, we can repeat ADOPT. So now every 15 years, we've had these big studies that tell us this approach won't work. I hope 15 years from now, we don't repeat this, because we're going to get the same result. Okay. Now, these are huge studies. There are, 17,000 people in this study. So I'm going to come back to the ominous octet for all of these drugs and show you where they work or don't work. So here is metformin and sulfonylureas. So metformin works here on the liver and only there. Okay. I told you, it gets into cells through the organic cation transporter. It cannot possibly get into muscle. So it cannot inhibit insulin sensitivity in the muscle. And we've shown that many times over. And it works here actually not by improving insulin sensitivity, but specifically by inhibiting gluconeogenesis. And Jerry Schulman and others have shown exactly what we've shown. And there's no effect on the beta cell whatsoever. Now, what about sulfonylureas? Now, where do they work? So you think Dr. Defronzo just lost his voice for the first time in his life? No, they don't work anywhere up there on a long-term basis. Initially, they will kick out insulin, but that is a very transient effect. So these are the two drugs that are right now, 45% of new drug prescriptions are metformin. Sulfonylureas are dropping. They're about 36% of new prescriptions, and 32% of new prescriptions are DPP-4 inhibitors. Those are the three drugs guaranteed not to work, okay? So here's now a very different picture, okay? These are the TZDs, pioglitazone and rosiglitazone. And when I gave the Banting lecture, there were 8 long-term studies, meaning at least a year and a half or more. They're all shown here. And you can see here, it's a very, very different picture. The initial drop in A1C is different because the study designs are very different. But whatever the initial drop is, the A1C stays down. And it stays down for up to 5 to 6 years. This is totally unlike anything I've showed you. It's unlike sulfonylureas, unlike metformin, unlike the DPP-4 inhibitors. So why is this? So over the years, we used this insulin clamp to measure insulin sensitivity. These drugs are truly insulin sensitizing drugs. So this is the rate of insulin-mediated glucose metabolism, yellow bar before. As Tracy said, I don't like to put too many bars, as Jerry doesn't like to put too many bars. You add pioglitazone, there's a 40% improvement in insulin sensitivity. Rosiglitazone, the same. So these drugs really are insulin sensitizing drugs. But the other thing that we showed is not only they're insulin sensitizing drugs, they have a huge effect on the beta cell. So the gold standard for assessing beta cell function is you do an oral glucose tolerance test, and then you're going to look at the increment in insulin or the increment in C-peptide divided by the increment in glucose. And then on a separate day, you do an insulin clamp, and you express how much insulin we secreted per severity of insulin resistance, okay? So the first 2 bars, we took drug-naive people, those are the yellow, before and after 6 months. No improvement when you treat with placebo and beta cell function. The next bar is drug-naive patients treated with pioglitazone. I triple your beta cell function. Rosiglitazone, 2.5-fold increase. And we also did it in people who are on other agents. The reason why the TZDs work so well is because they have not only good insulin sensitizing effect, very, very powerful effect on the beta cell. So pathophysiologically, And again, I could take you through the molecular mechanisms of all of this. Everything we've done is, I'm going to show you, is in humans. They're great insulin sensitizers in the liver. They not only knock down gluconeogenesis, but they truly improve insulin sensitivity. They're great insulin sensitizers in the muscle. They markedly inhibit lipolysis and increase glucose uptake in adipocytes, and they have a big effect on the beta cell. So if you correct 4 of the problems that are there from the pathophysiologic standpoint, these are going to be very, very good drugs for treating our diabetic patients. Now, we also have a big cardiovascular outcome study with pioglitazone. This is called the PROACTIVE study. And this should have been the first drug approved by the Food and Drug Administration. I'll tell you what happened, why it didn't get approved. There were 5,238 patients in this study. And to get in, you had to have a previous MI, stroke, something bad. Then half the people on placebo, other half on pioglitazone. And this is a Kaplan-Meier plot to the MACE endpoint. So MACE endpoint is major adverse cardiovascular events. In order to get a drug approved for an indication for cardiovascular standpoint by the FDA, you have to show the MACE endpoint benefits. That's non-fatal MI, non-fatal stroke, and cardiovascular death. Hazard ratio is 0.84. So it's a 16% decrease, and this is statistically significant. So why did this drug not get approved back in the 1990s by the FDA? Because this was the second principal endpoint. The principal endpoint was MACE plus leg revascularization. So the most important thing we learned from this study, you never let a surgeon run a cardiovascular outcome study. Second most important thing, you never let a vascular surgeon run a cardiovascular outcome study. Because Dr. Darnaby, who was the head of this study, insisted that leg revascularization had to be in there. I came close to strangling this guy at least a half dozen times because I kept telling him, leg revascularization doesn't respond to anything. You put that in there, and that's going to dilute down the results. So MACE plus leg revascularization didn't quite reach statistical significance. This did not get approved by the FDA. Now, the more recent study, I think, sheds even more light on how these drugs work, TZDs, and tied them very closely, something that Jerry was a big advocate of, tied very closely to development of insulin resistance. So this is what's called the IRIS study. So in the PROACTIVE study, the one that I just showed you, if you had a stroke and I put you on pioglitazone, recurrent stroke was decreased by 47%. So Dr. Kernan, a neurologist, and Dr. Inzucci at Yale knew this. And so they went to the NIH and said, we would like to do a stroke study. And in this study, to get into this study, and you can see it's a big study, almost 4,000 people, you had to have either a stroke or a TIA within the last 6 months, okay? But you could not be diabetic. And using HOMA-IR, which is a product of fasting glucose and insulin, you had to be insulin resistant. So HOMA-IR was greater than 3, so they're insulin resistant. And the A1C is 5.8. I'm going to come back to that in a second. So half the people on pioglitazone, half the people on placebo. And this is the Kaplan-Meier plot to recurrent stroke or cardiovascular event. And the orange curve is the pioglitazone. It lies above the yellow curve. And there's a significant decrease, 24% in recurrent stroke in cardiovascular events, okay? So if you now come back to that A1C of 5.8, so 5.7 and below is normal glucose tolerance, 5.7 above is pre-diabetes, because you couldn't be diabetic, okay? So that means half of the people in this study had normal glucose tolerance. The other half of the people were pre-diabetic. And it didn't make any difference whether you were normal glucose tolerant or you were pre-diabetic, okay? You got a 24% reduction in recurrent stroke and cardiovascular events, okay? So what this is saying is that the insulin resistance, okay, and this is something that Jerry said many, many years ago, is intimately related to accelerated cardiovascular disease. And what it's saying is that even from the atherosclerotic standpoint, we'll talk about this later this afternoon, when I talk about prediabetes, the insulin resistance is promoting atherogenesis. We did a lot of work to work out the molecular mechanism of this, which I'll review with you later. And pioglitazone actually reverses that molecular defect that's causing the insulin resistance that's promoting the atherogenesis. So pioglitazone is a drug that I like. It's one of the first-line drugs I use, but it's very difficult to get people to use pioglitazone because of all the misconceptions about pioglitazone. So one of the major misconceptions has to do with weight. And I'm not going to show you the weight data, but the more weight you gain, the greater the improvement in insulin sensitivity. The more weight you gain, the greater the improvement in beta cell function. The more weight you gain, the greater the drop in A1C. The more weight you gain, the greater the drop in systolic blood pressure. The more weight you gain, the greater the rise in HDL cholesterol. The more weight you gain, the greater the drop in triglycerides. Sounds like a terrible drug. I would never use this drug, right? Yeah, metabolically, it cures everything. Unfortunately, it makes you gain weight. And so cosmetically, people hate it. But you may live longer and be fat. So you have a choice. You can be fat and alive, or you can be lean and dead. Which one you want to pick? Okay, I think I'll go on the pioglitazone. Okay, now the other big misconception is that it causes heart failure and edema. And this is, again, people don't understand. Oh, that's me. Sorry. Okay. I hit this a couple of times. Okay. So the reason why it causes edema, it's a powerful releaser of nitric oxide. And nitric oxide is a powerful vasodilator. And so when you vasodilate, your blood pressure drops, you underperfuse your kidneys, a signal goes to the kidney, you hang on to salt and water, okay? That doesn't mean heart failure. So we did this study, and it's published in Diabetes Care, so it's not like some obscure journal. We took people who had diabetes, they didn't have heart failure, and we put them on pioglitazone, nice drop in A1C, with the insulin clamp, this is skeletal muscle. We double insulin sensitivity, exactly what we expected. But we also did the study with PET and fluorodeoxyglucose. There was a 75% improvement in myocardial insulin sensitivity. 73% improvement in skeletal muscle insulin sensitivity. And myocardial blood flow, you can see here, went up dramatically. Nothing increases myocardial blood flow like this. Any cardiologist here in the audience? Yeah, one. So most cardiologists, they don't like pioglitazone because they think it causes heart failure, okay? Well, this doesn't look so bad to me, okay? Oh, well, what happened to the ejection fraction? Oh, it only went up by 5%. This drug better than most of the drugs you use in your practice, okay? So if you look at the transmitral, these are all measures of diastolic dysfunction. The E over A ratio, also the E over E prime ratio, which is not up here, and diastolic volume and peak left ventricular flow rate, all dramatically improved. We've already started the HFpEF study. The first 6 patients in the HFpEF study, okay, 3 of them had edema. It's completely gone. They barely can walk across the room now. They're walking a half mile. So there are lots of reasons why we think that there are misconceptions, and this actually might be a good drug for treating HFpEF. But believe me, it's difficult to get people to use pioglitazone for all of these misconceptions in terms of heart failure and weight gain. Incretins, okay? So I told you when you ingest a meal, you release both GLP-1 and GIP, and they account for 70% of the insulin that's secreted in response to a meal. So this is clearly going to play a critical role in, determining glucose homeostasis. Now we have a whole slew of these ones. So the original one by Ada, exenatide, this was the injection twice a day. And I ran these studies, and I'll show you the data from them in a second. But no one is going to take an injection twice a day, okay? Then we had once a day with liraglutide, and then came the once weekly ones, exenatide, the two kind of, until recently, big guys were dulaglutide and semaglutide, and then now sort of Mounjaro is now fighting it out with semaglutide. But don't worry, in a year they'll be worthless because we got new ones that are coming, okay? So this one, ritutride, probably will give you 30% weight loss in obese people. And then CargiSema looks to be, it's a combination of amylin and semaglutide. That looks to be very similar to Mounjaro, okay? So why are these drugs so good? Well, of course, they're very good at lowering A1C, and they do so because they have a huge effect on the beta cell. And that effect on the beta cell seems to be preserved for upwards of 3 to 6 years. Knocks down glucagon. They're very good drugs at losing weight. We'll come back to this in a little while. It corrects 6 of those problems that are there in the ominous octet. They really have a good safety profile. And we know that from a number of studies, they do decrease the MACE endpoint. And we have at least one study, we haven't seen the final data yet, with semaglutide, showing that gives you renal protection. The hazard ratio that they put out in the literature is 0.80, meaning a 20% reduction in cardiovascular events. None of us have, I actually have seen the nitty gritty of the data. They look good. So we may be able soon to add renal here as well. So this is the original BIATA study. So for the, in all the groups, some people were drug naive, some were on sulfonylurea, some were on metformin, et cetera. Studies are all designed the same so we could do a meta-analysis. So for 30 weeks, you either got placebo or you got the drug. So placebo does nothing to A1C, drug lowers your A1C by 1. Starting A1C is about 8.1 in these groups. At 30 weeks, then in the yellow group, the placebo, we add the BIATA, A1C comes down, and then we continue the study for 3.5 years. So this is a very good effect, a nice drop in A1C, and it persists for upwards of 3 years. But no one's going to take an injection, as I said, twice a day. But the newer ones are once a week. Amgen has one that's coming every 2 weeks, and there are ones that are in development monthly basis, okay? So here now, until recently, these were the 2 big guys on the street, semaglutide and dulaglutide. Change in A1C, 1.8, 1.4. Now, you can argue over about 0.4 if you want. I would say, I don't really care whichever one's on your insurance you should use. This is a big drop in A1C. The SEMA always does a little bit better in weight, but this is a little bit biased because the dose of SEMA was 1, and you can go up to 2.4. So actually, you may even get more benefit here from the SEMA in terms of weight. But nonetheless, if you lose, these are in kilograms here. If you're losing 2 to 3 kilos, that's still pretty good. So here's the, here's the big guy now. This is the big dog on the street. This is Mounjaro, okay? And when the Hollywood movie stars, start using it, and you see them on TV going from like that to like this, of course, everybody wants to be on the drug. So this is tirzepatide and Mounjaro. You have to start at 2.5 milligrams and you titrate up to 15 compared to SEMA. Nice drops in A1C. So if your A1C is a 8.3 or so, as it was in the study, and I drop you by 2.3, basically half the people actually have a normal A1C. We've never been able to do this before. And you can see up to 12 kilograms body weight loss. These are diabetics. Obese people always lose more weight than diabetics. So the comparable thing would be about 18% body weight loss in obese people. So everybody wants to be on, one of these drugs, okay? And how do they work? The basically replacing the gut. I'm giving you a pharmacologic injection from the gut. Overcoming the insulin resistance, the GLP-1 resistance, the beta cell. I kick out insulin. I shut down glucagon. The rise in insulin, decrease in glucagon, shut down hepatic glucose production. I shut off your appetite, and then indirectly, because you lose weight, I improve insulin sensitivity. I correct 6 of the problems. These are going to be great drugs for our diabetic patients. Now, what about from the cardiovascular standpoint? They've basically all been tested. So from left to right, liraglutide in the leader, semaglutide in sustain 6, exenatide in excel, lulaglutide in rewind. And the orange curve is always to the right of the yellow curve. Hazard ratios are about 0.8 to 0.85. So there's about a 15 to 20% decrease in recurrent cardiovascular events in high-risk patients, okay? So here is the most recent of the studies. This is semaglutide in obese non-diabetics with a previous cardiovascular event or cardiovascular risk factors, okay? So this is now obese non-diabetics. So to the left, the MACE endpoint, this is a big study, 17,000 people, highly statistically significant, p-value is 0.8. Death from any cause, 0.81. So no doubt this drug works in terms of cardiovascular protection. It's great at making you lose weight. It's great at dropping the A1C. And the semi-renal study is quite positive. So why shouldn't we all be on these drugs? Okay, $1,000 to $1,200 a month. Multiplied by 12 months, you're looking at $36,000 to $40,000 per year. So I work in 2 places. I have the Texas Diabetes Institute, where 80% of our people below the poverty level. No one's going to get on this drug. Then I work at the university clinic, where all the rich people are, and they just buy it. It's not supposed to be prescribed for obesity, but because docs prescribe it for obese people, it runs out. And so a lot of my diabetic patients who I've had on the drug for 2 or 3 months now, they can't get the drug. And then I have to go through the whole titration again because they're off the drug for a month or so. So here's the big problem, which people don't appreciate. Obesity is drug addiction. It is absolutely no different from alcohol addiction. And if you think so, you're delusional. This is food addiction, okay? But for whatever the reason, we don't view food addiction in the same way as we view drug addiction. So if you look at people who are obese, the hedonic areas in the brain, the amygdala, the putamen, the prefrontal cortex, there's tremendous gray matter atrophy there. And there's marked disruption of the neural circuitry that's regulating appetite, okay? And this leads to food addiction. So now, if I put you on the drug, I'm just going to overcome the defects that are present in the brain. I will shut off your appetite, you lose weight. So as long as you're on the drug and you can afford it, you're okay. But you're going to be on this drug for the rest of your life. So first of all, as soon as you stop the drug, within 1 year, 80 or 90% of people regain all of the weight. Okay, that's just like alcohol addiction. There's absolutely no difference. Okay, they have different stigmata, of course. Alcohol addiction, oh, that's terrible. Okay, but food addiction, that's okay. You're obese. If you're obese, you may have a heart attack and stroke. Okay, you may get gallbladder disease, pancreatitis, arthritis, all these other things. We don't view that as being a serious disease, but quite frankly, it is a serious disease. And the other thing is, even though you're on the drug and you can afford it, half the people stop within 6 months. And there are all kinds of reasons why people stop. Some people stop because it's expensive. Some people just get tired of taking an injection every 6 months. Some people tell me, Ralph, it's a great drug. I can't eat anymore, and I like to eat, and they get an aversion to wine. That would be a destruction for Jerry. No red wine. Ralph and Jerry couldn't go out and enjoy dinner together. It would be terrible. So a lot of people just say, I'd rather get fat so that I can enjoy food. DPP4 inhibitors, very weak drugs. I don't use them. Okay, so this is saxagliptin, but I could show you any of them. Adding it to drug, glyburide, metformin, pioglitazone, you get about a 0.7 drop. Okay, this is a good drug if you have an elderly person and you need a very, very safe drug, incredibly safe, to drop the A1C, modestly. But other than that, I don't use it. The cardiovascular outcome studies, no cardiovascular benefit. The white curve is the placebo here, and then the colored curve is the drug. They're superimposable as you can in terms of, the Kaplan-Meier plot, and no renal benefit. Okay, so SGLT2 inhibitors. So this is a class of drugs which I actually invented. My significant other said to me one day, she said, Ralph, you're a pretty smart guy. And I said, yeah, I know that. And she said, you're one of the stupidest people I ever met in my life. And I said, what? She said, you invented this class of drugs and you didn't patent it? That was really stupid, believe me. So this market is like billions of dollars. And the first one that came to market is dapagliflozin. I actually did all these studies at Yale, and I published them in the JCI. This month, the JCI is celebrating their 100th anniversary of the JCI. And they've picked out, over the last 100 years, articles to feature. That sort of discovery that I made was an original JCI paper. It's actually reproduced. And for those of you who read it, I won't tell you, you should read the last sentence in the conclusion. The cardiologist and the nephrologist will like it in particular, okay? Well, we have 5 of them, and they're all very similar. They correct this defect at the level of the kidney where the threshold for spilling glucose is markedly increased. And now they allow you to dump the glucose in the urine. And high glucose, we showed over the years, causes insulin resistance, beta cell failure. I remove glucotoxicity, insulin sensitivity, beta cell function improves, okay? I reduce the A1C. You lose about 2.5 to 3 kilos in the first 6 months because you're losing calories in the urine. You can combine them with any other drugs because they work on the kidney and the other drugs work otherwise. These drugs are good at lowering blood pressure, no hypoglycemia, and because you're correcting some cardiovascular risk factors and some other things, which I won't have time to talk about, you'd expect cardiovascular benefit as well. So how do these drugs work? So this is a renal glucose titration curve. At some point, you all were medical students, you all learned about this, and then, of course, it wasn't important, deleted it from your memory bank. But it is important. So I start with a fasting glucose of 100. I infuse glucose. How much glucose appears in the urine? None until you get to 180. Then when you get to 180, all the glucose above that get dumped in the urine. Now, remarkably, when we started these studies, if you look at people who have an A1C of 6.5, this is sort of like the pre-diabetic person, the threshold is already increased to 205. If your A1C is 7.5, threshold goes to 220. A1C 8.5, et cetera, et cetera. So this is very paradoxical. The worse your control, the higher the threshold. We want your kidney to dump the glucose, but instead the signal is going to your kidney saying, hold on to the threshold. So how do these drugs work? So this is the normal person. I raise your glucose to 180, no glucose in the urine. After 180, you start dumping it. Here's the diabetic, threshold is increased. So now I put you on the SGLT2 inhibitor. Do I bring your threshold to 180? 100? No. I lower the threshold to 40. There is no such thing as a non-responder to this class of drugs. If I put anybody in this room on this drug, you would start putting out glucose right now, and you'd put out 60 or 80 grams of glucose in the urine, but your fasting glucose would not change. Within 15 minutes of the glucose appearing in the urine, your liver increases its production of glucose. So in the process of carrying out these studies, we discovered a whole new renal hepatic axis that had never, ever been described before. So once the glucose appears in the urine, you activate the renal nerves, and we've shown that if you block the renal nerves, but once the renal nerves are activated, signal goes to the liver, liver produces glucose exactly equal to the kidney. It's incredible. Your fasting glucose is 80, it stays at 80, okay? So these drugs can never cause hypoglycemia. And they are incredibly good for a lot of reasons. So if you look at insulin secretion, they get a big improvement in insulin secretion during the OGTT. This is getting rid of glucotoxicity. There are no SGLT2 inhibitors anyplace else other than in the kidney. And if you look at insulin sensitivity, because high glucose, this is glucotoxicity, causes insulin resistance, I improve insulin sensitivity. And then this gold standard of beta cell function is the increment in insulin secretion divided by the increment in glucose, factored by how insulin resistant you are, big improvement. So these drugs correct three problems. They get rid of the insulin resistance of the liver. They, of course, primary action is on the kidney, and they also improve beta cell function. They're good drugs for using in your diabetic patients. Cardiovascular disease, okay? This is the EMPA-REG outcome study. This was the first cardiovascular outcome study. The MACE endpoint, again, hazard ratio is 0.86, statistically significant. In the middle is the hazard ratio for death. And this is what got everybody excited. The hazard ratio is like 0.6 in heart failure. All of the other drugs basically do the same thing. The reason why they look more dramatic in the EMPA-REG outcome is because 100% of these people had a cardiovascular event, so they were very high risk. The dapagliflozin, the data are least impressive because 2/3 of those people had risk factors, not a cardiovascular event. In my opinion, they're basically all the same. Diabetic kidney disease. So the first one showing a benefit was the Credence study. So to get into Credence, you had to have diabetes, you had to have a low GFR, and you had to have protein in the urine. And the endpoint was having your GFR, a doubling of your serum creatinine, ending up on dialysis or transplantation. And you can see 0.66, 34% decrease in that endpoint. It's huge. And then those were all diabetic patients. And then came dapagliflozin. Same results as with canagliflozin, except 1/3 of the patients in the DAPA study were non-diabetic. So it didn't make any difference whether you had diabetes as the cause of your renal failure on non-diabetic causes. You still got this 30 to 40% reduction in ending up in dialysis or transplantation. So I told you it takes the American Diabetes Association a long time to change. I have to say, Jerry would pull his hair out as I pull my hair out, that it actually took the cardiovascular and the renal people to get the ADA to change. We've had these, yes, it's good, it's true. You changed way, way ahead of ADA, okay? We've had these cardiovascular outcome studies and renal outcome studies for decades. So finally, okay, in the past, first-line therapy always used to be metformin. In 2023, they finally changed, okay? So if you have atherosclerotic cardiovascular disease, first drug should be a GLP-1 or SGLT2, particularly if you have a heart failure, it should be SGLT2. Heart failure predominates SGLT2. Renal disease, SGLT2. Finally got away from metformin. Now, the problem with this, these people with heart disease and kidney disease, that's 20% of the diabetics. What are you going to do with the other 80% of the diabetics, okay? So there's a line over here, okay? You'll see why there's a line over here. The ADA finally made a change, a little one, okay, in the algorithm, okay? So what are these lines? Goal is get to less than 7. They finally acknowledge the DPP-4 is a weak drug, and so they move it down in the list. But the rest of this is totally insane, okay? They have GLP-1 here, that's good. Insulin, come on. A newly diagnosed diabetic patient with an A1C of 7.5 or 8, you're not going to start someone on insulin. Metformin, I already told you, it doesn't work. It's archaic. Sulfonylureas, forget it. SGLT2 inhibitors, good, TZDs. So this is a mix of 3 drugs that work and 3 drugs that don't work, all in the same line. Oh, but we got some benefit. We got DPP4 moved down a little bit, all right? Progress, all right? Now, in this day and age, we no longer pick a drug because it lowers A1C. It's got to do something else, okay? So yes, we want the drug to lower A1C, but we would like to give you cardiovascular protection. We want you to lose weight, okay? We want to prevent your kidneys, and the big kid on the block, NASH. We would like the drug to get rid of the fat in the liver and the fibrosis, okay? So you really need to be thinking about combination therapy. So I'm going to give you a couple of examples. So this is duration 8. So we're going to treat you with exenatide alone, dapagliflozin alone, or the 2 together. And we're going to look at A1C. So I drop you with DAPA about 1, 1.2 with the exenatide, and with the 2 together, 1.7. Clearly an additive effect. So these are 2 drugs working by different mechanisms. Put the two drugs together, okay? So now this study was a cardiovascular outcome study. So then they said, I'm going to take it monotherapy, and then I'm going to compare it with each one monotherapy, exenatide alone or DAPA alone, compared to the 2 together. If I look at composite cardiovascular benefit, the 2 together gives you a hazard ratio of 0.76, 24% better than either one alone. If I look at myocardial infarction, hazard ratio 0.71, or all-cause mortality. So clearly, when you put the 2 drugs together, you're getting cardiovascular benefit. So we said, we will take on the ADA directly and show you that their approach is as worthless as any approach you could ever do. So this is the EDI study. So it stands for Efficacy and Durability of Initial Combination Therapy in Type 2s. And so we took 2 newly diagnosed diabetics, and this is a big study. It's 318 people in 1 center, and very sophisticated measures. One group got the ADA approach. We started you on metformin. When you fail, we added glipizide, and then when you fail, you add glargine, okay? The other group got, right from the beginning, metformin, pioglitazone, and exenatide. Now, at the time we started this study, SGLT2 was not available. If I had to do it again, I would do it with SGLT2, okay? So the endpoint was how many people, okay, maintain the A1C less than 6.5, okay? So this is important. If your A1C rose above 6.5, you are out of the study. So the difference is not the difference in A1C between the 2 groups, because you got censored once your A1C got above 6.5, okay? So here's the A1C curves. They started with A1C is close to 9. The conventional therapy actually did pretty good if you just look at A1C. Not as good as the triple therapy, 6.9 versus 6.1. But remember, once your A1C got to 6.5, you were out of the study. So you couldn't get much higher. So here's the definitive endpoint. Yeah, I'm almost at the last slide. So the definitive endpoint is the percentage of people who have an A1C that's less than 6.5. 70% of the people had an A1C less than 6.5. 92% of the people have an A1C less than 7. Here's the ADA approach. 71% of the people have an A1C that is less than above 6.5. This is total failure of the ADA approach. Okay, about 3 slides I'm going to finish with. So why did you see this? Okay, so with the triple therapy approach, look what happened to insulin sensitivity. I basically normalized it. Why? Because I got pioglitazone and a little bit of weight loss, the exenatide. The conventional therapy did nothing. These are the most sophisticated techniques you can use to measure these parameters. Beta cell function. I virtually gave you a normal beta cell. The conventional therapy, basically nothing happened. And then if you look at carotid intermedial thickness as a surrogate measure, it progressed in the conventional therapy, and in the triple therapy, didn't progress at all, okay? So I'm gonna skip through these next couple of slides. So I would say, if you want to use the right algorithm, it shouldn't be the ADA algorithm. In my opinion, it's totally worthless. It's the Defronzo algorithm. There are 4 good drugs, okay? I put metformin at the bottom. It's still one of my good drugs, but it doesn't give you renal protection and it doesn't give you cardiovascular protection. The other 3 drugs all do. They're the drugs that correct the underlying pathophysiology, and they're the ones that are giving you the renal and cardiovascular protection. So those are the ones that I would use. This is very different from the ADA approach, although the ADA approach says, at least now, if you have kidney disease or renal disease or cardiovascular disease, you ought to be starting about the new drugs. So that was the last slide that I was going to show. And I'm more than happy to try to answer questions that anybody might have about it.
Thank you, Dr. Defronzo. We have a lot of people online, over 200, and there's lots of questions. I'm sorry.
I can stay as long.
Well, I'll turn over to Dr. McLaughlin. Wanted to ask a question here first, and maybe we'll do a couple.
Yeah.
I'm just asking this because I think that everyone might be interested in this, and your expert view would be great. But I was wondering if you wanted to comment on choice of drugs with regard to NASH and liver disease, since that's would be great to hear with your physiologic perspective.
Yeah. So NASH and liver disease, the best drug is pioglitazone. So we did the original study, Ken Kuzi and I. It's published in the New England Journal of Medicine some, I'd say 12 years ago. And it showed highly statistically significant changes, not only in steatosis, but in fibrosis. And that was 55 patients. We followed it up a year and a half later, increased the sample size to 150. There's no, I've said this to the FDA, in all of these ongoing studies with NASH, you should make them go against pioglitazone. Pioglitazone is $10 a day. I guarantee you, none of those drugs, including the recently approved one, the beta-3 adrenergic receptor, will beat pioglitazone. The GLP-1 receptor agonist, the semaglutide study failed. It got fat out of the liver, but no change in fibrosis. I think it's a mistake to think that a scar tissue is going to change. Once you get a scar tissue, it's not going to be removed. What you really need to do is a long-term study. So you have to say, I'm starting now and I have to see progression of fibrosis, new fibrosis. Can I stop that? That's going to take a long, long time, and I think is difficult to show. I actually think that the GLP-1 receptor agonists, if they did the studies long enough, would show it. But the only one now, and this was the Magridol study, was just approved last week, is the beta-3 adrenergic receptor. But I still think pioglitazone is the best one. Tough to beat pioglitazone.
Maybe I'll just get a couple online here. Dr. Golden had just asked, is only diet and exercise working? I think he was responding to a lot of your graphs that show things go up. So GLP-1s, SGLT2 inhibitors, do those medications have a long-term, GLP-1, theoretically, you're staying on it long-term. Do we believe those won't have an increase here in A1C?
Yeah. So the GLP-1 data I just showed you, those were 6-year data, if you didn't see on the axis. What happens after 6 years, A1C is down, the study only went on for 6 years. There is progressive beta cell failure. That, to me, is the genetic defect. So just like we see with bypass surgery, after 5 to 10 years, we start to see the A1C starting to go up a little bit. So I do think even on the GLP-1s, after 5 to 10 years, we'll start to see some failure, but at least up to 6 years in our hands, using one of the weaker GLP-1s, which is exenatide. But you have to remember, it was exenatide plus pioglitazone, not just the GLP-1 alone. The A1C is pretty rock solid.
Dr. Yaffe had asked, there's a GLP agonist, but GIP antagonist made by Amgen. Does the latter have implication in diabetes?
Yeah. So the Amgen drug is a very interesting one because it's a combination of GIP and GLP-1. But what's caused some controversy here is it's a GIP antagonist. And it's as good as the Lilly drug, which is a GIP agonist. So here we have Lilly with a GLP-1 GIP agonist. We have Amgen with a GLP-1 and a GIP antagonist, and the data look exactly the same in terms of weight loss, in terms of improvement of glycemic control. I have some thoughts about that. I think that the antagonist binds to the receptor, gets internalized in the beta cell, and when it gets internalized, it turns into an agonist to explain the, quote, paradox. The Amgen drug can be given every 2 weeks, so that is an additional week, but it looks very good as well.
Can I have one more? Dr. Clark, a cardiologist, he was asking, he's noticed that the normal glucose tolerance versus impaired glucose tolerance was greater than the difference between impaired and type 2 diabetes. To what extent should we be treating, should we be treating pre-diabetes? I know you're talking about this afternoon, but can you give us an insight?
Yeah, so I'm talking about pre-diabetes this afternoon, and we've done the study. It's called the ACT NOW study. So people treated with pioglitazone, there was a 75% decrease in the conversion rate of pre-diabetes to diabetes, and 58% of the people went back to normal glucose tolerance, huge improvements in beta cell function and insulin sensitivity. So I would say we should be treating early. Dr. Berry.
So I'm going to ask a very naive question. It was a beautiful talk. I always learn from you since I'm an intern. So if you just have a fresh diabetic,
Yes.
and you're looking at cost,
Yeah.
and looking at adherence,
Yeah.
and say their hemoglobin A1C is 7,
Yep.
what do you start with?
You put costs in there. Yeah, I'll repeat it. Yeah, so Dr. Berry say, look, if I have to take into account adherence, cost, and efficacy, what would I start? So I would always start in combination, okay? But if you put cost in there, $1,000 a month will exclude the GLP-1 receptor agonist for most patients. So that takes out the GLP-1 RAs. So that leaves you with metformin, pioglitazone, SGLT2 inhibitors. Now, I'm assuming these are newly diagnosed, so they don't have renal disease or heart disease. If they did, then I would definitely have the SGLT2 inhibitor. I would say the most cost-effective in those two would be metformin and pioglitazone. Metformin is like $5 a month in the state of Texas. Pioglitazone is $10 a month, and you don't have to go to the 45 milligram dose. At the 30 milligram dose, edema is very uncommon. You don't gain much weight. So the cosmetic part of the pioglitazone is not there, but all the other benefits are there. And in the IRIS study, which I showed you, the people who had stroke, where we put them on pioglitazone, and we saw the dramatic reduction in recurrent stroke. Silvio Anzucci and I, we did a sub-analysis where we looked 15 milligrams of pioglitazone did as well as 30 milligrams, did as well as 45 milligrams. So even the lower dose of 15 or 30, you get all the cardioprotective effect, and you don't get the edema and the weight gain, which makes people feel better, although those are cosmetic issues. Now, if you tied my hands behind my back and said, no limitations, and I only could pick one drug, I would pick the GLP-1 receptor agonist. There are some safety issues that I didn't discuss, but clearly if you have $1,000 per month and you're overweight and you're diabetic, that would be the class to go with, and you can afford it. But that's expensive. Yep.
Dr. Defronzo, that was amazing. Thank you so much.
Okay.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.